Good morning, good afternoon, good evening to everyone listening to us. Welcome to the COVID Dialogue. Thank you for joining us. As you know, this is a series of discussions we are having with experts both from the high resource settings and low middle income countries and relatively low resource settings. And the purpose of these dialogues is to learn from each other, as we have seen over the past few months, a few weeks, that for COVID, the resources hasn't mattered so much. Countries that felt very confident about their abilities to respond to emergencies have done relatively poor, while countries with limited resources have done relatively better, actually. So the purpose of this collaboration between the Aga Khan University's Center of Excellence on Trauma and Emergencies and Johns Hopkins Center for Global Emergency Care is to have a dialogue of equals such that we are learning from each other and not telling how to do things to each other. So with that, again, my name is Junaid Razak. I lead the Center of Excellence at AKU as well as Center for Global Emergency Care at Hopkins. And it is my pleasure to request my two colleagues to introduce themselves. Let me start with Asad, who is the senior of the two. And Asad, I know you're mute, but I can see you. And could you briefly introduce yourself, your background, and where you are right now? And then I'll ask Adam to do the same thing.
Sure. Assalamu alaikum. Thank you, Dr. Zak, for this opportunity. My name is Asad Latif. I'm currently the chair of anesthesia at Aga Khan University in Karachi. And fortunate to be so. But before, I've been here for 8 months now. Came in last July. Before this, I did my residency in anesthesia in the US, my fellowship in critical care, also in the US, and I was on fellow and faculty at Johns Hopkins for over a decade, where I was fortunate enough to get the opportunity to do a master in public health also, and have been an active researcher in quality improvement and patient safety, and the focus in low resource settings, particularly in the ICU setting. So now currently at Aga Khan University, which is a 760-bed hospital in Karachi, tertiary care, where we are at the forefront of helping lead some of the work in along taking care of COVID patients, but lead some of the work in care of these this pandemic.
Thank you, Asad. Adam.
Sorry, I just had to get my microphone unmuted. Good morning, everybody. Good evening, good afternoon. Salam alaikum. My name's Adam Laytin. I'm an assistant professor of emergency medicine and critical care medicine at Johns Hopkins. Did all of my training in the United States, although I've had a long-standing collaboration with physicians and policymakers in Ethiopia around building critical care capacity there. My research interests mostly relate to injury epidemiology, trauma and critical care systems, and system strengthening in low resource settings. It's a pleasure to be here with you guys all today. Like Dr. Razak said, this is always an interesting opportunity both to hopefully share a little bit of knowledge and to learn from the participants in the room as well.
Thank you, Adam. So the way we are going to structure today is, and we are evolving sort of every week, is Adam and Asad are going to present some slides, and that will take about a combined of 10 minutes or so. And then we would like to open the discussion through your questions. I have a bunch of questions that I have written, but I really appreciate if the audience who are listening, based on the presentations, can send us those questions, and we would share their slide with the questions as soon as the presentations are done. So with that, Adam, you want to start?
Sure. And so I doubt that I'm going to, let's make sure it's working. I doubt that I'm going to say anything that's completely shocking to anybody in the room. And these are numbers from Friday, so they're already outdated, unfortunately. As we all know at this point, the COVID-19 pandemic has swept the globe over the last few months. There are about 2.2 million cases worldwide at this point, and 150,000 deaths worldwide. I think what's really remarkable about this is that there's been a tenfold increase in the number of cases in the past month. So only in the middle of March, there were about 220,000 cases worldwide, and that's, like I said, increased tenfold. And when I checked numbers again last night, it had gone from 2.2 to 2.4 million in just 3 days. So continuing to rise quite precipitously. There are between 70 and 99,000 new cases per day. We haven't quite crossed the 100,000 cases per day threshold, for whatever that's worth. But that's more cases, new cases per day than there were worldwide 2 months ago. I would love to be able to say that we know what the true case fatality rate of coronavirus is. This is going to continue to evolve over time as we gather more data. At this point, it is influenced by the true population prevalence. We don't really have the testing capacity anywhere in the world that I know of to know what the true denominator of that equation is, as well as the demographics of the population. We know that older and sicker patients are more heavily affected, more likely to die of the disease, as well as the health system capacity. We do a lot of talking in the United States about social distancing and trying to flatten the curve to make sure that we don't have so many patients that the healthcare system's overwhelmed, and then our patients aren't able to get each benefit from the best possible care that we have to offer. And then as we develop more treatments over time, hopefully the mortality rate will go down as well. This was a graph from a study published in JAMA last month comparing case fatality in China and Italy. So China had a 2.3% case fatality rate. Italy had a 7.2% case fatality rate. But as they break it down by age demographics, you see that most of this reflects the fact that they had more elderly patients over 70 years of age in Italy than they did in China. But across demographics, case fatality rate was pretty similar between the two countries. Data on the resources required to care for these patients is just starting to come out. This was a study from the New England Journal last month, looking at about 400 inpatients with coronavirus in New York. A third of those patients required mechanical ventilation, and 10% of those patients needed to be intubated and put on a ventilator within the first 3 hours, so while they were still in the emergency department. They were seeing about a 10% mortality rate, but that was still with a quarter of their patients still inpatient and not yet discharged. 15% of patients who were ventilated died, and almost another 10% didn't receive mechanical ventilation. So likely those were patients who were either DNR, DNI, who didn't want to be placed on a mechanical ventilator, or would raise questions about if they had the capacity to care for all of those patients, or if they had already overwhelmed their system at that point early in the pandemic. One other brief study looking at specifically critical care patients in Seattle, and this was only 24 patients, 3/4 of whom required mechanical ventilation, but they were saying that the median duration of mechanical ventilation was 10 days in those patients. But that said, when they published this report, only a third of those patients had been extubated. So clearly these are patients who are going to have significant ongoing ventilator needs. These aren't patients who are going to turn around in a day or two most of the time. They were finding a median hospital length of stay of 12 days, a median ICU length of stay of 9 days. This also was a study that was published as that they had not graduated all of their patients from ventilators or from the ICU at the time that these numbers were published. So just the beginnings of a snapshot of the scope of care that these patients are going to require as they receive care in our hospitals. The last thing that I would toss up just before we move on to more of a discussion there's an idea of the iron triangle in healthcare where you try to balance between quality of care, access to care, and cost of care, with the idea that you can never perfect those three variables. And whenever you improve two, you're probably going to hurt the third side. I think there's a parallel in management of coronavirus patients, where they're probably the things that are the best for the patient, the best for the providers to keep us safe and prevent infection of healthcare workers, and things that are best for the healthcare system with limited resources to optimize our ability to care for the community as a whole. So as we talk about what are best practices, what would be recommendations for care, often these are things that will focus on one or two of those three sides. I don't think that we found the perfect solution that addresses all three of those sides equally, maybe until we get a virus or a more effective therapeutic intervention. A lot of our management is really trying to balance those three priorities. Asad, I'll apologize. I have your guidelines, but wasn't able to fit them onto slides. I'm happy to pull them up if you'd like, or to have them as a reference as we move forward. Junaid, I think you're muted.
No. Dr. Junaid, you're on mute.
Sorry, I was telling Asad that he's on mute. Asad, based on what you heard from Adam, and I know a lot of work has happened at AKU preparing for this and responding to this, would you like to share your current practices or give some ideas to the audience on how you are looking at this from the ICU perspective, and then we can open it for question answers.
Sure. Thank you. So, this has been a unique disease and a unique problem around the world. And what we're seeing, Adam rightly presented a bunch of data, and the data is showing variations across the board around the world, right? What is obvious is that this is a big problem, and rates are still just increasing, but they're doing it at different rates. And low and middle income countries seem to have not been hit as hard as a lot of the high income countries have. There's a variety of reasons, potential reasons for this. Nobody really knows. I'm sure you, like many others who are Facebook or on YouTube or WhatsApp, will be subject to a lot of possibilities and theories. But the reality is it's probably based on hard science. The countries that seem to be less hit are ones that are low-income countries, have worse or less sophisticated data collection methodologies and culture. Therefore, that probably contributes. The other thing that probably contributes is the demographics of their population and how the population pyramids are significantly different from most high-income countries. For example, in Pakistan, where more than a third of the population is under 15 years of age, the burden of the disease is naturally going to be different from the US or the Western world. We're seeing something not dissimilar from that in Pakistan, where a lot of, we don't seem to have as high a prevalence of critically, or as high a proportion of critically ill patients. However, the ones who are getting critically ill are not the typical elderly over 65, 70, 80 that are being reported in the literature from places like Italy and Spain. A lot of the critically ill that we're seeing are on the younger side, in the 30s, 40s, 50s, and are people who are showing an interesting pattern of respiratory failure. The symptoms that are presented have varied widely. And in our population, what we're seeing more of is people presenting a little bit further in their disease course at the time of presentation. For example, in the ERs, they might actually show up once they have respiratory distress, or be further along in their severity pathway. So therefore, we have been having success stories. We do have our bunch of patients in our ICUs, but again, the use of ICUs in a low-income setting like Pakistan, and as a disclaimer, I will like to admit that at Aga Khan University, it's far more comparable to a high-income country and a high-income setting and resource setting than a true low-income setting, as you would find in rural Pakistan or in outside the city of Karachi. We are seeing patients who are made with ICU are ones who are actually they're ventilated or in true respiratory distress requiring supplemental oxygen, not supplemental oxygen, but respiratory support. So those patients are still few and far in between compared to the larger number out there, and far less than what I assume Dr. Laytin is probably seeing at Hopkins right now, where I think at last guess, I think I heard him say almost 40-50% of patients with COVID are ventilated. There's many nuances, but so far it seems like we're a little bit less hit as far as the compared to the US.
Got it. What I'm going to do now is share with everyone this slide. You've seen this slide, those who have joined us before, and it basically gives you the email address where you can write a question. So there you go. It is coe.te@aku.edu. I have a couple of questions that I want to start with, starting with the question about how do you decide who you're going to put on the ventilator, and especially in the context of limited vent supply, and limited vent supply today is applicable to as high income country as US and in the context of New York or in Pakistan. So can you, maybe Adam, I can start with you, and you work in the emergency department as well. Who do you intubate? And then there's a lot of discussion on, should we intubate early or late? What are your thoughts? And then Asad, you can add on, please.
Sure, it's a great question, and I don't think that we know the perfect answer to it. I think this is a perfect example of that sort of iron triangle question. And so really the question is, who are we looking to optimize benefit for? For the healthcare workers, intubating early is for sure the safest thing to do. You want to have time to have your PPE on, which can be onerous and take some time. Make sure that you have all of your resources arranged. We try to use a video laryngoscope whenever possible to minimize aerosolized secretions getting directly into the face of the intubator. And so having things organized to have everything go smoothly, and when a patient isn't in decompensated respiratory distress, is clearly the best thing for the providers. For the patients, there's some interesting debate about this in the literature, and something that we haven't really answered yet. For sure, I've seen the cases where a patient is sort of off the proverbial cliff, decompensated respiratory failure, who as soon as they get RSI drugs, desaturates and is peri arrest. And you want to save patients before they get to that precipitous decline, and that can happen quite quickly. So also, I think that we've been under the belief that intubating patients sooner than later is probably in the patient's best interest to have their airways secured and to take over some of their work of breathing for them with a ventilator before they acutely decompensate. There is some signal coming out now that maybe for some of those patients who are earlier in the course of their disease, there may be some barotrauma or some biomechanical trauma from having those patients on the ventilator early and struggle against the ventilator desynchronous. That still is really being worked out in the literature. There's some interesting theoretical concerns there that haven't really been answered. I think the last question then is, what's the right thing for the healthcare system? And that's going to be a moving target for all of us based on the availability of ventilators, of ICU beds, of intensivists that we have. If you're able to temporize somebody with 24 hours of high flow nasal cannula and cut their ventilator time down by a day, that could be a 10% increase in the number of available ventilators that you have and 10% more patients that you're able to care for. So at some point, the idea to try to delay intubation to optimize your resource utilization is a concern as well. But I wish I had a better magic bullet answer.
No, this is good because I think there's a lot of obviously discussion on that topic. Asad, I have a specific question for you. I have a question from Dr. Natasha, and she's asking, when you look at the needs of critical care healthcare workers, equipment, ICU beds, and then compare it to the capacity in say Pakistan, what are your thoughts about that? How do we respond to this big crisis given the shortages at multiple levels?
That's a very good question. I guess I'm not answering the other one. Critical care really has to be thought about as, it all depends on what your perception of critical care is, right? Is critical care an intensive care unit or an ICU bed, or is it the care of those who require, that are higher acuity or require a higher level of care provision, which can take the form of a higher level of training or understanding of that sort of pathology? So is it care provided intensivist? Is it care provided with a higher acuity of nursing, with a 1-to-1 ratio of nursing who follows the patient on a minute-to-minute basis? That's really what the question boils down to. In terms of Pakistan, critical care, while that was provided, but ICU care has been lacking severely. For example, in the province of Sindh, there's probably in the public sector, there's probably under 50 ventilators in the entire province of Sindh, which is tens of millions of people, right? However, they do have facilities, and what people are working on, and the government is working actively on, is to increase that capacity manyfold. And I think there are plans to get it in the hundreds of ICU beds within the next few weeks to month. So that they're trying to move towards that. However, people need to realize that things are not automatically that easy. When you're trying to increase capacity in the healthcare sector, you need to look at 4 things. And I'm going to borrow liberally from Partners in Health and Paul Farmer's framework. You need stuff. So you need the right equipment. You need space. You need the right location. You need staff. So you need the right people. And you also need the right systems, right? Because all these things together will allow your healthcare system to take care of the people that need care. So critical care is no different from that. And in Sindh, at least, and across Pakistan, they're trying to increase ICU capacity in terms of getting the stuff available and the spaces being made available from other areas. Fortunately, this is a good time for that because other demands in the healthcare system are decreasing, so hospitals have space, which might not originally have been used for providing critical care. What's really left is the staff and the systems, and that's where expertise comes in, and leveraging our existing resources comes in, right? It's not like you can grow an ICU nurse or an ICU doctor in a matter of days or minutes or buy them. It takes years and years of training to do so. So leveraging your existing resources to cover those deficits is really where the focus has to be. And in fact, as you might know, Dr. Asad, Aga Khan has recently gotten into an agreement with the government of Pakistan and the government of Sindh to try and help train up the existing people, personnel, to a certain level of competence in critical care, and also for the higher acuity patients, provide an element of consultation and expert panel to help provide that expertise required to care for these critically ill patients. Naturally, there are going to be disparities in this, but we are actively trying to, so these sort of public-private partnerships are going to be needed. And it's not just public-private partnerships, but partnerships across the board between private institutions, between all kinds of healthcare providers to try and leverage existing resource and existing knowledge and expertise to see how we can provide care to those who need it, where and when they need it.
Great. Asad, a related question about your agreement with the Sindh government. How do you plan to support those ICUs? Is it online, like live support, or is it mostly training?
So we're in discussion about that. Again, it's not my agreement; it's the Aga Khan University's agreement. I'm just a small cog in that machine. But what we're trying to do is do a little bit of both, right? What you have, if you just look at numbers, for example, in Sindh, if for example they're increasing their ventilator capacity tenfold or more, that's great. But then you have people who've never seen ventilators before, right? And now they're going to be asked to take care of intubated patients and all these ICU patients. The training is really there to help them have a certain understanding and overcome their, for lack of a better word, hesitation or fear when they're taking care of these ICU patients, and know enough to give them best care possible in the shortest time possible, but also know when they can when to ask for help. And there are tremendous expertise across the country between various medical critical care doctors, between various anesthesiologists who often are the critical care providers in a health system like Pakistan, and emergency physicians who often provide critical care. So these three groups have been doing it historically in Pakistan, with anesthesiologists in most British systems taking the lead. To do that, so once they know where to call for help, we are also going to pilot a program where we will provide a hotline number where people can call and get expertise from a trained critical care provider in referral to that specific patient and that specific patient's problem. That is still being worked on, that model, but that's our goal. It should, hopefully, in my mind, to be most effective, will need to be multiple hubs like that with multiple people to meet the overall need. But it is really a matter of leveraging the small force. For example, I think there is maybe just a few dozen FCPS2 passed critical care physicians in Pakistan. That is not a huge number at all for a country of 220 million, but you need to leverage those people to their maximum impact. And there's many others who have been providing critical care for years and years, but might not have been doing it through the classic model.
Right. Great. Adam, a couple of questions from Dr. Najib. First, he's asking, are you using ARSNet protocol or something close to it at Hopkins? And secondly, to both of you, experience regarding prone ventilation.
Sure, so a couple of great questions. So, and I'll take them backwards maybe. So in terms of prone ventilation, we've definitely seen improved oxygenation in patients, especially ventilated patients who are in hypoxic respiratory failure with prone positioning. It's something that helps to manage these patients while their disease process runs its course. We don't have any effective therapeutics at this point that are convincingly shortening the duration of the illness. The prone positioning has been one of the more effective interventions to improve oxygenation in patients with hypoxic respiratory failure. We have some patients who will show up and, you know, as they get positioned in the emergency department and placed on nasal cannula, automatically lie themselves on their bellies and say, I know that I'm supposed to be proning myself because on the news they say this works. And there have been some reports of awake proning patients, mostly I think on high flow in New York, that have also been able to delay intubation for those patients, at least temporarily. Actually, if you don't mind, I'm going to put up a slide that I modified from a recent publication by Dr. Gattinoni in Italy, because I think that he's getting at something very interesting that we haven't totally figured out.
Sure.
Let's see if, But essentially, he's hypothesizing that there are at least two different phenotypes of COVID patients.
You want to share your slide?
Yeah, I'm trying to.
Okay.
Sorry, I have too many things open on my desktop, so it takes me a minute to find the PowerPoint again. So he's hypothesizing that there are different phenotypes of COVID, at least one of which is similar to conventional ARDSnet, or normal conventional ARDS as we understand it, for whom ARDSnet ventilation is probably the right thing to do. So he says that there's an early phenotype that he calls the L phenotype or the low phenotype. These are patients who have low elastance and so high compliance, lung low weight, so low degrees of pulmonary edema, and are already pretty well recruited and may not benefit as much from higher PEEP and proning. And then there's the H phenotype, which is much more like what we think of as normal, traditionally described ARDS. These are patients who have high elastance, so low compliance, high degree of pulmonary edema, and may respond better to recruiting strategies like prone positioning and higher PEEP. He thinks that this low group is hypoxic because of pulmonary artery vasoplegia and shunting, as opposed to ARDS physiology. And so those patients the low phenotype may not need to be intubated as urgently, may be able to tolerate higher tidal volumes and don't need as much PEEP or proning as opposed to the high phenotype. We don't know if this is an evolution where patients go from one to the other, or if those high phenotype patients are ones who've developed a super infection with a bacterial pneumonia or another septic physiology, or if something about those patients is causing them to develop the pathophysiology of ARDS. We have a strong culture of ARDSnet here at Hopkins. Some of the early ARDSnet proponents and sort of godfathers are still faculty here. And I think across the country, it's hard to argue against something called lung protective ventilation. You know, it's like asking somebody, would you like to fly on the safe airplane or the other one? Everybody's going to choose the safe airplane. I think if you give somebody the option, would you like to do lung protective ventilation or lung hazardous ventilation? Everybody's going to choose lung protective ventilation. But we're also seeing that some of those patients with COVID hypoxic respiratory failure who are on ARDSnet with high PEEPs and low tidal volumes are having a lot of dysynchrony requiring tremendous amounts of sedation to help them to cooperate with a ventilation strategy that they may not actually be benefiting from. So I think the jury is still out there. That still is our starting point, would be something like 6 per kilo and increasing our PEEP as we're increasing our FiO2 along with the ARDSnet tables. We've been using the high PEEP table to start with. But I think it's important, if you have the capacity to evaluate for compliance as you're up titrating PEEP, to see if you're actually recruiting more lung, or if you need to be using low tidal volumes because of poor compliance. Looking at somebody's driving pressure to get a sense of how much potential ventilator-induced lung injury you're causing can be really helpful.
Great. Asad, any comments on that?
I actually would like to second what Adam's saying and what Galiloni evidence was suggesting. So we have been seeing some stuff like that in the sense that patients functionally some patients seem to functionally have a shunt that responds to FiO2 a little bit more than PEEP, and the classic ARDS ventilation where low tidal volumes, a higher PEEP, and very strict PEEP to FiO2 pairings. We have had some success with not intubating patients, but it has been variable. A lot of patients have skimmed the treetops, so to say, and 3 or 4 days later, turned out that they need to be intubated. But we've had some successes where after skimming the treetop for 2 or 3 days, they've just pulled up and gotten better. the risk-benefit ratio over here really comes down to the healthcare providers, though. And that was our early thinking. And in a resource-limited setting like Pakistan, that probably factors in a little bit more than at a place like Hopkins. The main issue being aerosol generation, which can happen at a higher frequency almost continuously with things like high flow nasal cannula, which there's not much of in Pakistan, but like BiPAP and non-invasive ventilation can definitely lead to more aerosol generation than an endotracheal tube, right? Because once you're intubated, after the active intubation, most aerosol generation will probably be around suctioning the tube, which you can overcome with inline suctioning or oropharyngeal suctioning, or whenever the circuit disconnects, or when you nebulize, or those sort of things. Because of that, those practical considerations need to be taken into account about whether we can get along with non-invasive ventilation or we should move to intubation. That being said, in Pakistan, again, bypass are a little bit more common than non-invasive ventilation. We also have a lot of social or cultural angst against the act of ventilation. We've had patients refuse to be ventilated or go on the ventilator, and it's almost like culturally, some people will consider it like it's a fate worse than death, or it is right next to death, whereas that is not necessarily what we're seeing out of this patient population. It's primarily the elderly, and by elderly I mean over 70, 80, who once again ventilated are the ones who end up having poor outcomes, but those in their 30s, 40s, depending on the phenotype and how aggressive they have gotten worse, their acuity has changed, will probably do okay or recover. That being said, the duration of ventilators from literature is in the double digits. So anywhere from 9 to 21 days, which again is a very necessary consideration in a place like Pakistan, where it's an out-of-pocket healthcare health payment system, and it can be a struggle for patients themselves and their families, and a burden that needs to be taken into consideration. So all in all, maybe that sort of data has been promising, and maybe we will do better with non-invasive than the other high-income country literature says. And we have to remember, most literature is coming out of high-income countries, so it does provide a certain shading to viewpoints.
Great, thank you. Now comes the, I find it really challenging, this question from Dr. Sadaf Hanif. And she said that ethically, could intensivist make elderly COVID DNR? And she used the without family consent. Again, it's a very loaded question. But I think generally speaking, we've heard about in Italy, especially in Spain, where right at the front door, patients who were at certain age were refused ventilation. I'd like to hear your understanding and your thoughts in your own context. Adam, why don't you go first, and then Asad, you can come in.
Sure, and it's a great question, a very topical question, one that we've discussed here, although luckily haven't had to make those sorts of decisions at this point. We also had the incredible luck that one of our medical intensivists, Lee Doherty Biddle, had done a study over the last few years talking about the potential of a healthcare disaster that overwhelmed our critical care infrastructure. That I think was a wonderful, very useful study in guiding how we think about these sorts of issues, where she met with healthcare workers as well as community members from around the state and talked about hypothetical scenarios where triage of a limited resource like ventilators would be a consideration, and collected data, collected opinions from people about if that were to happen, how would we as a community want to prioritize resources? What they found was that they did not think that age itself should be or not just they, but the healthcare providers and residents of the state didn't think that age itself should be a determining factor, but how likely somebody is to benefit from ventilation, how likely they are to recover, and how much expected long-term life they were expected to have after they recovered. So somebody who was 30 and healthy, who you were expecting to go on to have another 40 or 50 years of life after their recovery from their acute illness, maybe somebody who you would prioritize over somebody who was 95 with multiple significant medical problems, who you wouldn't expect to have another 40 or 50 years. But maybe somebody who's 30 with end-stage cancer, metastatic cancer, who only had a 6-month prognosis prior to becoming sick, their youth shouldn't be the factor that would get them a ventilator over somebody who is 70 and you were expecting to live for another 20 years if they recovered. There was also some discussion about whether healthcare workers should be prioritized, with the understanding both that we're putting ourselves at increased risk by taking care of these patients and that we deserve some special consideration for that, as well as the fact that if you save the life of a healthcare worker, we may be able to go back to work and care for more patients, and so you may be saving more lives that way. I think that the important thing is having this not be a decision that a physician's making solo at the bedside. If you're able to get input from the community at large, I think that's incredibly beneficial. Even short of that, having an ethics committee in the hospital that's divorced from the clinical team that can help to mitigate those decisions. I think that we as clinicians all are most comfortable and most effective when we are advocating for our individual patients who we have a personal relationship with. And I think it puts us in a very problematic situation where I might say, okay, I'm not going to intubate this patient who I think needs to be on a ventilator. If, on the other hand, there's an ethics committee that says we have 3 ventilators for 10 patients, and we're going to use some objective criteria to decide which of those 3 patients, or which of those 10 patients get those ventilators, knowing that the physicians are all going to do their best to advocate for their patients, but that final decision doesn't fall on the clinician, I think is a much more ethically and morally acceptable position to be in.
Thanks. Asad, for you, this is even a bigger challenge, right? You have a relatively less number of ventilators. You're expecting maybe much more in the future. How do you see this decision making happening in your setup? Mute.
This is a valid question, Dr. Azad, and an important one, right? We've actually given it some thought at Aga Khan University, and we are working on an iteration of some sort of framework and document to help with resource allocation in this sort of in the current pandemic. But the 2 or 3 principles that Adam mentioned are the same ones that we were trying to build this on. And I'll admit others beyond me, smart people, have been taking the lead on this. The principles have really been around making sure that the triage is based on some sort of relatively objective criteria. It is separate, the decision making is separate from the person or people taking care of the patient themselves to allow for some element of fairness and impartiality. And the third point is really being clear and honest about communication to not only between the providers, the decision makers and those who have to implement it, but also with the families upfront. And then all these processes need some sort of appeal process for exceptions because they always can occur. The trickiest thing really ends up being how can you make objective criteria for something that we don't have that much evidence for. People have tended to go back on to existing evidence on things like SOFA scores or other scoring systems. SOFA is the easiest. However, that, for example, is based primarily on has a heavy component of respiratory failure and physiologic parameters, which, if you look at the literature, might look a lot worse than they actually are. Adam gave that example of looking like ARDS, but not quite acting like it in terms of the ventilator requirements. So, and then the evidence, it doesn't take into account what the evidence shows about how people with multiple comorbids or certain comorbids like diabetes, hypertension, fare worse than those without. People who are older definitely have a higher preponderance of bad outcomes than those who are younger. For example, mortality in people under 10 is almost negligible, like a fraction of a percent, whereas it's in the teens once you start getting over 60, over 70. So those sort of things probably require some sort of combination between people who are using things like clinical frailty index or something in combination with actual physiologic parameters. I think Pittsburgh has put out something, the University of Pittsburgh has put out something that has been probably the best combination that I've read about so far. And what we're working on is probably going to be better with that. However, it is still a limited resource. The question about healthcare workers getting some sort of preference has definitely been something discussed in the literature. It was something that we didn't quite feel comfortable including in our research group because our resource is just so limited and our need is potentially so great given our population. It's going to be a challenge, and you know, our culture of acceptance is also very different. In terms of DNR, that is a tricky concept in low resource countries, especially Muslim countries, where there is definitely a concept of people are more in touch with their mortality and fatality and have somewhat of a fatalistic view. However, it can also be not indigenous, but a society where things can escalate very quickly. As you, who've been an ER physician in Pakistan for many years, probably know, things can escalate very quickly. So the key really is setting expectations upfront and also having a fair and transparent process, which is what we're going to work towards.
Yeah. Thank you. And I think, you know, with years of practice, you know, at AKU, with where you are, Asad, the training that we get as clinicians, at least in emergency medicine, was airway, breathing, circulation, control the airway, find the ventilator, put the patient on it, and many a times there are infectious reasons, pneumonia and other things, and they will eventually get better. But then very soon I sort of realized that the question was not about that, but actually about not having a vent, and in that situation, would intubating, paralyzing somebody is really helpful or harmful? And I still don't know the answer to that question. We'll go to this other very interesting discussion that is happening in many places, is about the ventilator splitters. And some of our own friends have put out videos on how to use those. I'd like to hear your thoughts as ICU critical care physicians on the role of that. It, to me, is really weak, but love to hear, how do you see this being used? Asad, you want to go first?
I was hoping that Adam would go first. No, absolutely. You're saved, Adam. Yes, I think we've all seen these videos, and all of us are working on trying to find viable solutions for that. It is, as you know, sir, far more tricky than it looks on a YouTube video. Ventilators are highly sophisticated, highly specialized machines that are sophisticated not only in terms of hardware, but probably far more sophistication is in their software, right? Which is why when Elon Musk, for example, promised 10,000 ventilators, what he actually delivered were BiPAP machines, not ventilators. And so it's not like anybody can make them, there's a blueprint to it. The problem with the ventilator splitting really is a ventilator is designed for one person, and it's not just the hardware, which can easily split into 5, 10, 20 pipes so that you can deliver air to everybody. It's also the software, which makes sure that the precise amount of air or pressure or volume is delivered to the right person, and then senses and corrects for that over time, right? And it's really that issue that holds up this splitting, because the splitting isn't enough. In basics of ventilation, you can either control volume or you can control pressure. You can control both. So just imagine multiple patients who have, if they're exactly the same compliance, the ventilator will distribute air and tidal volumes equally. However, if they start changing in compliance, so you have two patients on the ventilator. One is, they both have the exact same compliance when you start out, but one is on day 2 of an expected 10-day course. And the second one is on day 8 of expected 10-day course. So one is going to get worse, the other is going to get better, right? The compliance will change. They might start at the same place, but as the compliance changes, the amount of volume delivered each will change also, because the ventilator can only sense things at one point, the way it's currently designed. So one person start getting more air at the expense of the other person over time. The one with the worst compliance will get less air, where better compliance was getting better, will get more air. So that's a problem, right? To really split, you have to not only be able to deliver air, but you also need to be able to measure pressure and volume, and ideally even regulate it at each patient's level, which is not what a simple splitter can do. And that requires some more sophisticated monitoring into that. Not just that it's not impossible, but it's definitely engineering complexity is far beyond just printing out something with 4 outputs and 1 input. We at Aga Khan University, like others, are also working on this. Whether we're successful or not, we'll find out soon. But yeah, it's not as easy as it looks. Yeah.
Adam, what do you think?
I agree with everything that Dr. Latif said. Couldn't have said it better myself. I think he's right on that this is not a simple, straightforward endeavor. We also have folks in our biomedical engineering group who are working on sort of smart ventilator splitters. I think that we as intensivists are very good at doing things in a very controlled, highly regulated way. And there are a lot of things that are beyond the scope of what we're comfortable with. And I think that's true for physicians in general, for healthcare workers in general, that a pandemic that's overwhelming our healthcare infrastructure is taking people well beyond the things that they're comfortable with doing, and forcing us to think quickly on our feet about how we can adapt to new demands that force us to operate outside of sort of our comfort zone. And so, like Asad said, we don't have the technology to split ventilators safely at this point. A lot of people are working on developing that technology. I don't think it's beyond the scope of reason that we're able to figure out ways to adapt ventilators to use that sort of technology. And if you have 2 patients in 1 ventilator, that may be the best way to provide the maximal benefit for the maximal number of patients. I think that for a lot of aspects of adapting to the COVID pandemic, that advanced preparation, drilling, simulating, or sort of practical approaches to figuring out what are going to be the logistics and the kinks, whether that's how it would look to try to put 2 patients on the same ventilator, or how do we prone a patient in our healthcare setting, or how do we make sure that we have appropriate PPE to intubate a patient safely, are things that you don't want to have to do the first time when you have a patient dying in front of you. You want to be able to figure out how you can mobilize those resources and drill it, practice it, so that when the time comes to be proning an unstable patient or trying to split a ventilator, you figured out, how to get the iron out the wrinkles, get the kinks out of the system so that things work smoothly. So I think it's great that people are working on developing this now before we've needed that technology. It's a fascinating time to be practicing medicine.
Great, thank you.
And in fact, Dr. Asad, I would actually build on that. I mean, I think my focus would really be, in this time, since somebody brought that up, we have a certain limited number of ventilators. The government Pakistan's ordered, I think, 10,000 more. We don't have necessarily the manpower to run existing ventilators. We don't have the nursing capacity. We don't have the intensivist expertise. So I think we can optimize what we have first. For example, at Aga Khan University, you have dozens of ventilators. We have less than a dozen people who were critical care trained, far less. I think there's 6 or 8 people. We have at the present moment 3 or 4 services that they'll be splitting into. And let's say we have 40, 50, 60 ventilators. For us to be able to handle that is going to already stretch our capacity. Johns Hopkins, for example, as an almost 1,000-bed hospital, has probably 400 or 600 ventilators. You probably know better, Adam. I would be highly suspect if they can run the existing ventilators. Splitting them and taking care of more patients is a next level problem that hopefully we'll never get to. But we'll probably struggle with making the most of what we already have. So we should probably focus on that first.
Yeah, I agree. Just to build off of that, and somebody had asked a question in the Q&A document about using virtual ICU. I think we've also been doing some thinking and trialing how it would work to have intensivists supervising other groups of physicians, so that maybe one intensivist could be caring for or supervising the care of 50 patients instead of 10 or 20 patients. There are a lot of things that we're going to do. They're going to expand the scope of practice that we're comfortable with and that we're used to. And so we've been trying to drill some of that. We've started doing some sort of virtual rounding where the intensivist will sit in an office while the resident and fellow are at the bedside nurse rounding with the nurse, and the other clinicians on the team are in a different conference room to see how this would work if we were sort of socially distanced on rounds. There are a lot of kinks to work out of that sort of a system also. I think that there's a lot of feasibility to it. But again, I'm glad that I've had some practice in figuring out what works, what doesn't work with trying to round remotely before we're really pushed to do that on more patients than we're used to, with less trained providers working together on that. I think that the things that I would say no, it's never something that we could possibly do suddenly become possibilities when the patient population and the disease burden puts you to that test. That said, virtual ICU is difficult. There's a lot that you get out of actually being at the bedside with the patient, both in terms of interacting with the patient, providing support for the patient, for the family, but also just things that you see in terms of patients' work of breathing or their ventilator dysynchrony or their volume status. I don't know a good way to evaluate without just being at the bedside with the patient myself.
Wow, we almost, we are a minute before we have to close down, and there's still a number of questions that remain unanswered. My sense is from the discussion is there's a lot of innovation. There are a lot of ways we are trying to help our patients. From the discussion, looks like you guys are not as worried about managing the pathology itself. It's about the system of care and availability of resources, which appears to be more of a challenge. We would come back to hopefully you in next few weeks, and by that time we'll be as medical experts more smart about how the disease is progressing, and also we'll have a session on ethics. So we look forward to engagement and help from you and others. With that, I'd like to thank you both, Adam and Asad, for taking out time. I know how busy you are, and your families obviously are missing you and want to spend more time. So thank you so much for being here with us. And thanks to our team in Pakistan with Talha and the IT team and Batul to help us out with this session, as well as my team here at Hopkins. Thank you all, and we'll see you again next week, next Monday. Thank you both.
Thank you, Dr.
Yeah,
Thanks, everybody. Pleasure to be with you.
Nice seeing you, Adam.